Hi, this is Dr. Poole, back at you again with now the topic skeletal muscle disorders and their associated pathology. There's a lot of overlap and things in common in the pathology of myopathic disorders. So I'm going to start off with some of the things that are common to most, if not all, of the myopathies. Skeletal muscle atrophy is a common but non-specific feature of many of these disorders, but you can use certain patterns of atrophy, and those are best appreciated using different histochemical stains to suggest specific underlying etiologies. Skeletal muscle injury may occur by denervation or neurogenic injury, or may be primary to the muscle itself. Disruption of muscle innervation leads to two types of characteristic injury, known as fiber type grouping and grouped atrophy. Remember that muscle fiber type is determined by the innervating motor neuron and can switch if the innervating motor neuron changes from one type to the other. So let's look at that in more detail. Panel A at the top left shows a diagrammatic representation of four normal motor units with a normal checkerboard type of admixture of light and dark stained fibers of opposite type. Panel D, just to the right of it, shows normal muscle with a checkerboard type of distribution of type 1 light staining and type 2 dark staining fibers on this ATPase reaction, corresponding to the findings in Panel A. Following denervation, myofibers undergo atrophy, often assuming a flattened, angulated shape. Panel B shows damage to innervating axons, leading to loss of trophic input and atrophy of myofibers. Panel E shows clustered, flattened, angulated atrophic fibers, known as grouping atrophy, which are a typical finding associated with disrupted innervation. Reinnervation restores fiber size and shape, but may make denervated myofiber part of a different motor unit, and that may lead to a switch in fiber type. In the face of ongoing axonal or neuronal damage and dropout, residual motor axons may innervate increasingly larger numbers of myofibers, leading to enlargement of motor units, each comprised of a single type of muscle fiber, known as fiber type grouping. These large motor units are also susceptible to group atrophy if the innervating axon is damaged. Panel C depicts this process where reinnervation of myofibers can lead to a switch of fiber type and segregation of fibers of like type. As illustrated here, reinnervation is also often associated with an increase in motor unit size, with more myofibers innervated by an individual axon. As shown in Panel F, with ongoing denervation and reinnervation, large clusters of fibers appear that all share the same fiber type. This is known as fiber type grouping. Next, I'll talk about some morphologic patterns that indicate primary myopathic injury to skeletal muscle. Segmental myofiber degeneration and regeneration is seen when only part of a myofiber undergoes necrosis. Degeneration is associated with release of cytoplasmic enzymes into the blood, such as creatine kinase, making these useful markers of muscle damage. The sarcomeres and other components of a damaged myofiber segment are removed by macrophages in a process called myophagocytosis. This sets the stage for regeneration. Fusion of activated satellite cells to damaged myofibers is an important step for regeneration. Eventually, new sarcomeres are generated and the continuity of the original myofiber is restored. Regenerating myofibers are rich in RNA, and so they'll stain blue or basophilic in routine hematoxylin and eosin stained sections. They have enlarged nuclei with prominent nucleoli that are often randomly distributed in the cytoplasm instead of being in their normal subsarcolemmal location. Depending on the nature of the primary insult, atrophic myofibers may also be seen. Regeneration can restore muscle to normal following an acute transient injury, but in chronic disease states, like we're talking about in this section, regeneration often fails to keep pace with damage. In this setting, muscles can often show endomysial fibrosis or collagen deposition, dropout of myofibers, and fatty replacement. Myofiber hypertrophy occurs in association with certain chronic myopathic conditions, as well as the well-known physiologic adaptation to exercise. Think Hans and Franz. Cytoplasmic inclusions in the form of vacuoles, aggregates of proteins, or clustered organelles are characteristic of several primary forms of myopathy. I'll only talk about one a little bit later in this presentation. But these are useful markers for specific myopathic diseases. The first of the disease entities I'll talk about are muscular dystrophies, or dystrophinopathies. The changes in Duchenne and Becker muscular dystrophy are similar but differ in degree. These are a group of several inherited disorders of skeletal muscle that have in common progressive muscle damage that typically manifests itself between childhood and adulthood. Both are marked by chronic muscle damage that outpaces the capacity for repair. Muscle biopsies in young boys show ongoing damage in the form of segmental myofiber degeneration and regeneration associated with an admixture of atrophic myofibers. The fascicular architecture is preserved at this stage of disease, and there's usually no inflammation except for the presence of myophagocytosis. As the disease progresses, muscle tissue is replaced by collagen and fat cells, known as fatty replacement. The remaining myofibers at this point in the course show prominent variation in size, from small atrophic fibers to large hypertrophied fibers. This remodeling distorts the fascicular architecture of the muscle, which becomes markedly abnormal over time. You can use immunohistochemical stains for dystrophin to show the absence of the normal sarcolemmal staining pattern in Duchenne muscular dystrophy and reduced staining in Becker muscular dystrophy. Patients with DMD classically present around the age of 3 years with gross motor delay, excessive falling, and gait abnormalities. Enlargement of the muscles of the lower leg associated with weakness is called calf pseudohypertrophy, and neck flexion weakness are evident by 3 to 4 years of age. Hip girdle muscles are typically affected sooner than shoulder girdle muscles, causing the classic waddling gait and Gower's sign. As the disease progresses, weakness spreads distally, joint contractures can develop and further worsen gait abnormalities. If untreated, DMD follows a fairly predictable progressive course. Children lose the ability to walk, typically by 10 years of age, and always by 13 years of age, then develop kyphoscoliosis, and finally develop cardiac and respiratory involvement and respiratory failure in the second decade of life. In contrast, Becker muscular dystrophy presents later in childhood, adolescence, or adulthood. It follows also a slowly progressive course, but is a much milder clinical phenotype, and patients have a near normal life expectancy. These are images from various stages of Duchenne muscular dystrophy. To the left, in early stages, fascicular muscle architecture is maintained, but the myofibers show variation in size. Additionally, as indicated by the blue circle, there's a cluster of basophilic regenerating myofibers, and slight endomysial fibrosis is seen by the focal pink staining connective tissue between the myofibers. In panel B, immunohistochemical staining shows complete absence of membrane-associated dystrophin, as seen in comparison to the brown stain in normal muscle. In panel C to the right, the muscle illustrates disease progression, which is marked by extensive variation in myofiber size, fatty replacement, and endomysial fibrosis. This is a muscle image from a middle-aged man showing atrophic fibers and fibrosis. This immunohistochemical stain for dystrophin reveals only small amounts of dystrophin, typical of Becker muscular dystrophy, which is less common and less severe than DMD. The same dystrophin gene is involved in BMD, but with a different mutation than in DMD. Some dystrophin is made in BMD, but not in normal amounts. Myotonic dystrophy is a clinically and genetically heterogeneous multisystem disorder which follows an autosomal dominant inheritance. It's characterized by skeletal muscle weakness and myotonia, that is, abnormally slow or delayed muscle relaxation following normal muscle contraction, cardiac conduction abnormalities, cataracts, and other abnormalities. It's the most common muscular dystrophy in adults of European ancestry. It follows a slowly progressive course with weakness of facial and neck muscles in contrast to muscular dystrophy, and has a characteristic facial appearance including frontal balding, ptosis, wasting of the sternocleidomastoid and temporalis muscles, producing a hatchet-faced appearance. This is the characteristic facial features of myotonic dystrophy. Myotonic dystrophy is also contrasted with muscular dystrophies in terms of its extraskeletal dystrophic features. It's associated with several endocrinopathies, including hypogonadism and diabetes mellitus, a cardiomyopathy, and cataracts. It has a complex genetic pathogenesis, which I won't go into too much detail, mainly because I don't understand it that well, but involves expansions of CTG triplet repeats in the 3' non-encoding region of the dystrophia myotonica protein kinase gene. It's interesting in that this exhibits genetic anticipation, which is a phenomenon where disease manifestations get worse with each generation. So it has some similarities with another disease that I'm sure you'll talk about in the next course, Huntington disease. Myotonic dystrophy doesn't really have any specific pathologic features, but typically shows features of regeneration and degeneration noted by the centrally located nuclei indicated by the arrowhead in these myofibers seen cut in cross-section, along with the typical variation in fiber size as well as fibrosis. Next topic is the inflammatory myopathies. This includes polymyositis, dermatomyositis, and inclusion body myositis. Polymyositis and dermatomyositis are idiopathic inflammatory myopathies characterized by inflammation of striated muscle, that is myositis, and characteristic cutaneous features in dermatomyositis. These diseases typically present as insidious, painless proximal weakness. Extramuscular disease can also occur. Both PM and DM may present as isolated idiopathic syndromes or may overlap with other autoimmune diseases such as systemic sclerosis. PM and DM are characterized by insidious, progressive, painless muscle weakness over a course of several weeks to several months. It is often accompanied by myalgias, which is typically mild. Weakness is usually proximal and symmetric, and less frequently involves the distal muscles. Some of the symptoms or signs may be difficulty rising from a chair, climbing stairs, or combing hair. Extramuscular disease may occur with polyarthralgias or polyarthritis, most frequently affecting the hands, wrists, and knees in a rheumatoid-like distribution. The arthritis, however, is usually mild and non-deforming. Dysphagia may occur in up to a third of patients and is due to weakness of the oropharyngeal muscles or striated muscles of the upper third of the esophagus. Patients complain of difficulty swallowing, nasal regurgitation, dysphonia, and may have lung aspiration. Raynaud phenomenon may be seen and is associated with the antisynthetase syndrome. Interstitial lung disease is common and may even be the presenting finding in patients with PM and DM. It causes dyspnea and cough. Patients with idiopathic inflammatory myopathies usually present with slowly progressive lung disease. Note that dyspnea and cough may also be the result of respiratory muscle weakness or aspiration pneumonia due to pharyngeal weakness. Calcinosis is more common in late stages of chronic DM and can be quite disabling. Sites of trauma are usually affected, and periarticular calcification can be seen with joint contractures. Overlying skin may ulcerate over these calcium deposits and may be complicated by infections and draining sinuses. Finally, cardiac involvement is frequently present but usually asymptomatic, with only electrocardiographic abnormalities noted. It's only a rare cause of congestive heart failure, myocarditis, or symptomatic pericarditis. Skin lesions differentiate DM from PM. Various rashes have been described with dermatomyositis, but the most common characteristic ones are a lilac-colored discoloration of the upper eyelids associated with periorbital edema, called a heliotrope rash, and a scaling erythematous eruption or dusky red patches of the knuckles, elbows, and knees, which are called Gautran papules. This slide just illustrates some of the signs and symptoms that can be seen with polymyositis and dermatomyositis. It's important to note a variety of secondary causes of dermatomyositis, particularly associated with malignancies, in which these are a paraneoplastic syndrome, as well as association with other autoimmune diseases, particularly systemic sclerosis. Dermatomyositis is also characterized by juvenile and adult forms. The average age of onset of juvenile DM is 7 years, whereas adult cases tend to present from the 4th to 6th decades of life. Dermatomyositis is also the most common inflammatory myopathy in children. Compared to adult disease, childhood disease is more likely to be associated with calcinosis and lipodystrophy, and less likely to be associated with myositis-specific antibodies, cardiac involvement, interstitial lung disease, or an underlying malignancy. As might be expected based on these differences, the overall prognosis is better in children than adults. Polymyositis is characterized by marked chronic inflammatory cell infiltrates, indicated by the arrowhead, with degeneration of muscle fibers as part of this disease. As you might suspect, serum creatine kinase is markedly increased. Polymyositis results from the cytotoxic effects of CD8-positive lymphocytes recognizing antigens on the myofiber sarcolemmal membranes. In contrast, dermatomyositis is mainly mediated through a CD4 helper lymphocyte mediated vasculitis, which affects small capillaries, and so the distribution of changes will be different. We'll see that in the next slide. Panel A shows the typical heliotrope rash, which affects the eyelids and underneath the eyes. The right panel shows the histologic appearance of muscle in dermatomyositis, which shows a distribution of perifascicular atrophy of muscle fibers and inflammation, the location of which is highlighted with the blue lines. The other major inflammatory myositis is inclusion body myositis. This is a disease of late adulthood that typically affects patients older than 50 years and is the most common inflammatory myopathy in patients older than 65. Most affected individuals present with slowly progressive muscle weakness that tends to be most severe in the quadriceps and the distal upper extremity muscles. Dysphagia from esophageal and pharyngeal muscle involvement is not uncommon. Inclusion body myositis has a number of features that are similar to those found in polymyositis, including patchy, often endomysial mononuclear inflammatory cell infiltrates, focal invasion of normal appearing myofibers by inflammatory cells, admixed degenerating and regenerating myofibers. But other associated changes are more specific for inclusion body myositis, and these include abnormal cytoplasmic inclusions, described as rimmed vacuoles, as shown in this image, and tubulofilamentous inclusions in myofibers seen by electron microscopy. The cytoplasmic inclusions contain proteins that are typically associated with neurodegenerative diseases, such as Alzheimer's disease, and include the proteins beta-amyloid, TDP-43, and ubiquitin. Finally, with chronic disease, nonspecific endomysial fibrosis and fatty replacement can be seen in other chronic myopathies. And finally, nematodes. Hopefully this has satisfied your hunger for skeletal muscle pathology, but I'll end up with nematodes. Notice that Dr. Richards has included some content as this as well, but I just wanted to show you the characteristic pathology. This is trichinosis. Encysted Trichinella spiralis larvae, as shown by the arrowhead, are shown within the skeletal muscle. A heavy infestation of larvae, as depicted in the right panel, can actually lead to death. Most cases, however, go unnoticed, and the encysted larvae undergo dystrophic calcification over months to years. So that ends this talk on skeletal muscle diseases and their associated pathology. Please refer to the notes as well, which contain additional content. And if you want to, this is purely optional. You can follow along in the readings that are in the study guide. Thanks.